Hello everyone, I'm Dr. Xiang from EGE Hospital in Shanghai, China. Today I'll be presenting on the prognostic utility of microvascular obstruction persistence as assessed by cardiac MRI in patients who have suffered a ST elevation myocardial infarction or STEMI. This work is an analysis of the early mild CMR registry. I have nothing to declare. Let's begin with a brief introduction to set the stage. ST elevation myocardial infarction remains a leading cause of death and disability worldwide. Timely percutaneous coronary intervention is the standard of care to restore blood flow to the heart muscle. However, a problem often remains at the tissue level. Despite a successful PCI, over 50% of patients develop microvascular obstruction, also known as no reflow phenomenon. MVO is the hallmark of severe myocardial injury and a robust predictor of poor long-term outcomes, including adverse remodeling, heart failure, and death. This brings us to the core motivation of our study. On contrast-enhanced MRI, microvascular obstruction is a dynamic process. The area of no MVO visibly changes in size between early scan and late scan. Despite this, the current clinical standard is to assess MVO using a single static snapshot from the late Galilean enhancement or LGE images. So the question is, by using a static solution for a dynamic problem, are we missing the crucial information here? The static approach completely overlooks the temporal dynamics of MVO. We hypothesize that the persistence of MVO from the early to the late scan reflects a more severe irreversible injury and could provide additional prognostic value beyond the standard static assessment. Therefore, the objective of our study was to formally evaluate the prognostic utility of measuring MVO persistence between early and late GAD enhancement images in post-STEMI patients. Now, let's briefly go over our methods. We conducted a retrospective analysis of multicenter early mild CMR registry. Our final cohort consisted 584 patients with first STEMI who were treated with PCI and underwent a cardiac MRI within 1 week. The primary endpoint we tracked was major adverse cardiovascular events, or MACE, which is a composite of all-cause death, heart failure, hospitalization, and reinfarction. The median follow-up was 3.1 years. To capture the MVO dynamics, we quantified the MVO volume on both early and late Galilean enhancement images. From this, we developed a MVO persistence index, which is simply the ratio of MVO volume on the late image to the volume on the early image, expressed as a percentage. This index allowed us to classify each patient into one of the 4 distinct microvascular perfusion patterns. As you can see, there are 4 patterns. They range from no MVO, where no obstruction is visible at either time point, to reversible MVO, where early obstruction disappears by the late scan. The last 2 categories are for the patients where MVO is present on both scans. We defined partially reversible MVO as having a persistence index below 40% and persistent MVO as having an index of over 40% or greater, indicating a large portion of the initial obstruction remained. The 40% threshold was derived from the ROC analysis for predicting MACE. Our key finding was that MVO persistence is a powerful and independent predictor of MACE, as you can see clearly from the Kaplan-Meier curves on the left. Patients with the persistent MVO pattern had a dramatically higher incidence of adverse events. More importantly, this was not just a simple association. After adjusting for all established risk factors, including age, LV function, and even the static MVO measurements, the MVO persistence index remained a strong independent predictor with a hazard ratio of 1.36 for every 10% increase. The persistent MVO pattern itself carried a more than 5-fold increased risk of MACE compared to those having no MVO. When we broke down the MACE endpoint, we found this increased risk was primarily driven by the heart failure hospitalization and reinfarction. Patients with persistent MVO pattern had a 7-fold higher risk for heart failure hospitalization and a staggering 11-fold higher risk for reinfarction. Interestingly, we did not find a significant association with all-cause mortality. Finally, we wanted to see if our dynamic assessment could add value to the existing risk models. Here, we compared our MVO patterns to the established Canadian Cardiovascular Society or CCS classification. As you can see from the diagram, our dynamic MVO patterns provide a much more refined risk stratification. Specifically, the persistent MVO pattern identifies a very high-risk group with an annual MACE rate of nearly 17%. This is the risk level not captured by the CCS stages, demonstrating clear added value of assessing MVO dynamics. Let's now briefly discuss the implications of these findings. In essence, our study shows that the dynamic assessment of MVO provides significant independent prognosis information. This value is incremental to all established clinical and static MRI markers. The persistent MVO pattern successfully identifies a group of patients at markedly elevated risk, likely because it reflects a more severe, irreversible form of microvascular damage that isn't fully captured by a single static measurement. The clinical impact here is significant. This dynamic assessment can be easily incorporated into routine MRI protocols without any extra scan time or contrast. It offers a simple way to enhance risk stratification and help clinicians identify high-risk patients who may benefit from intensive management. Of course, our study has limitations. It is a retrospective analysis. The 40% threshold was derived internally. Therefore, prospective studies are certainly warranted to validate these findings. In conclusion, the persistence of MVO from early and late gadolinium enhancement is a powerful, independent predictor of adverse outcomes after STEMI. Assessing these MVO dynamics significantly enhance the clinical utility of cardiac MRI for risk stratification in this high-risk population. Thank you for your attention.